There we go. All right, so today we are going to talk about surveillance, infectious diseases, and outbreak investigation. So this is kind of what people think of when they hear the phrase epidemiology, if they've ever heard it before. Most people, you say epidemiology and they go, what? And they're like, is that the study of skin? Like, no, that's the epidermis. So people typically think of infectious diseases when they think of epidemiology, because usually when you hear epidemiologists referred to, it's in the context of some outbreak type of scenario when H1N1 was flying around and people were really worried about it. The CDC tends to send out their epidemiologists to curb public panic, but also to do the research into finding these outbreaks. So that's kind of what we're going to talk about today. Up until now, we've really kind of talked more about the chronic disease aspect of epidemiology, which is really more where Epi and health services research are really aligned. But outbreak investigation stuff is still necessary, and it's still something I want you to know about. So we're going to talk about that today. Let's see. Excuse me. So surveillance is really used to assess the public health status. So we've kind of alluded to the aspect of surveillance up until this point, but surveillance is really when you have some systematic method for watching the population for the occurrence of a particular disease or illness. So public health surveillance systems really need to have the capacity to collect and analyze the data, to disseminate the data to public health programs, and to regularly evaluate the effectiveness of their disseminated data. So surveillance, we have surveillance for both infectious disease and for chronic disease. We use it both things. So when you have who's heard of the behavioral risk factor surveillance system? It's abbreviated as BRFIS. You'll hear people call it that. But so that's a surveillance system for behavioral risk factors. It's a big, huge survey that the government sends out every year to a random sample of people. And that's how we get all of how many people are exercising rates across the United States. And so we get a lot of information from that. We have a lot of other nationwide surveillance systems. There's also surveillance systems for things like West Nile virus. So we have it both for infectious disease and for chronic illness. But the point of a surveillance system is that you want to detect changes in disease distribution. So generally speaking, there's always some underlying base rate of disease going on. So there will always be, once West Nile virus reached the U.S. at least, there will always be like a couple of cases a year. There's a base rate of the endemic disease. However, what we are looking for with surveillance is not to identify that base rate. We're looking for deviations from that base rate. We're looking to see, is there a huge spike in the cases of West Nile virus? So we use surveillance to look at for early detection of these disease changes, also to collect data about new diseases. So when West Nile virus first appeared in the United States, we didn't know a lot about it. So we wanted to learn more who it was affecting, where it was affecting, the person, place, time, descriptive epidemiology that we've talked about up to this point. We can also use our surveillance systems to evaluate our control measures. So we recognize that there's a problem with excess disease in a particular area, and we implement some intervention to try to combat that. We can use our surveillance system that helped us identify the problem in the disease in the first place. We can use that same surveillance system to help us evaluate whether or not our control measures are working. We also want to look for the prevalence of infections in a population. And then we use surveillance of immunization programs so we can identify who's being immunized, are all the appropriate people being immunized, are there pockets in the country where people are not immunizing for various diseases. Typically when that happens, you tend to see outbreaks of a particular disease in that area. But I'll get on that soapbox a little bit later. Surveillance methods. So there's different ways of collecting information about disease distribution. Based on the type of methods, you can be more or less confident about how valid your answer is. So population-based methods really are talking about complete reporting of the entire population. So for example, birth certificates and death certificates are population-based surveillance. Every person that's born in the United States gets a birth certificate, technically. maybe one or two who don't. But really, in the grand scheme, everybody in the population has a birth certificate, everybody in the population has a death certificate. So those are population-based methods. We can look for the prevalence of illness, or we can look for the prevalence of certain characteristics based on that at a population level. Some cancer registries also provide population-based surveillance data, because there are some cancer registries that are designed to register every single person that has that particular type of cancer. So that would be a complete sample of, or a complete list of the entire population of people that have that cancer. Not all cancer registries do this, but there are some that do. Population-based methods of surveillance are our ideal method. They're exceedingly expensive and very rare, right? Because it would be highly impractical to ask every single person in the United States how often they exercise each week, right? Probably not easy to do. Hence the fact that most of our surveillance methods are done from representative samples. So, representative samples are randomly drawn samples from your desired population. So we've talked a lot previously about random sampling. So there's different methods of doing random sampling, but representative samples are population-based random samples. So instead of using the entire population, surveying the entire population, we instead take a random sample of the population, and then we can apply our inferential statistics in order to expand what we learn from that sample to the population. That's typically what most surveillance systems use. Convenience samples are simply samples of convenience. We're taking the people that are easily available to the researcher. Convenient samples are subject to extensive bias, so they're not representative of the population, because there's no guarantee that the people that end up in your sample are representative of the population as a whole, right? So you really can only talk about the people that were in your sample when you're using convenient samples. So, one method that we can use for surveillance is to examine the rates of disease. So we can find rates of common disease for national and statewide populations. Typically, the federal and state governments just collect that information routinely. So if you're interested in a particular disease state, you can just go on the internet and go to the CDC's website and look up the rates of disease for whatever disease you're interested in. It can be difficult, however, to find rates for smaller geographically defined populations. So the government typically will break things down for you at the state level, sometimes at the county level. But if you're interested, and sometimes they break it down by census tract, but if you're interested in like one particular city, you may not be able to break down certain disease rates from existing data that the government already collects. You could always collect that information yourself, but that's going to be quite expensive. All right. So which data do you think is better for estimating disease rates? Incidence data or mortality data? First off, what's incidence? We're going to review.
Number of new cases.
Number of new cases of disease. What's mortality?
People that die from the disease?
Yes. People that die from the disease. Which one do you think is better for estimating disease rates?
Incidence.
Incidence. Yes. Why?
Because more than likely we already have the data on the people who have disease, for your example of the cancer registry. So the new folks coming on board, the incidence would be, I guess, more proactive data that we could act on.
Well, let's not talk about how we're gathering the disease. Let's just talk about why incidence would be a preferable measure of how many people have the disease compared to mortality.
Data being better than, I would think it'd be best if we could reach the folks who are alive to help them.
Right. Why? But not about. But why do we want the number of new cases of disease if we're trying to count the number of people that are sick? Why would we want the number of new cases of disease and not the number of people that died from the disease?
I'm compelled to use that data to help them get better.
Even before you get there, we're not even helping people yet. Before you get there, why is the number of new cases of disease a better estimate of the number of disease in the population than the number of people that died from the disease? pass?
Confounding, I don't know.
We're passing on. You're jumping way ahead of the game. Like you're on the right track, but you're 2 steps ahead.
If you die, you don't have the disease anymore. So, like, there's, I don't know.
Even before that, what if we want to estimate
Not everybody dies.
the common cold? Not everyone dies, right? So if we use mortality data, we're probably not going to get everybody. Now, there are some diseases where pretty much everybody dies, so mortality data is probably a pretty good estimate of the number of people that got sick. However, it's a little bit further down in the chain, which leads back to where you were jumping to, was the fact that you can't really help people once they're dead. But, yeah, so we want the incidence because not everybody dies from particular disease. And if we're really trying to assess how big of a problem the disease is within our population, we want to know how many people actually got sick, not just how many people died from it. The problem is, a lot of time mortality data is the only data that's available for some things. So, we use mortality data when incidence data is not available, or when the case fatality rate is high. So who remembers what case fatality rate is? That was like the first or second week of class that we talked about case fatality.
This is the people that already have the disease but have died from it. Out of everybody that has the disease, they're the people that have died.
Yes, it's the number of people that died out of everyone who had that disease. Exactly. So if your case fatality rate is high and most people with the disease die, then if you use mortality data, you're still getting a relatively good estimate of the number of people that had the disease. Let's see, lost my place. Yeah, no, sorry, that's what I was trying to say. All right, but so preferably we want incidence data. If we can't get incidence data, we can use prevalence data or we can use mortality data. But generally the goal of surveillance is to identify the disease distribution, to know the base rate of disease, and to be able to identify any alterations in the base rate, see if something's happening somewhere. So that could be geographically, it could be temporally, but we're looking to see if something's different. There's lots of places where we can get all this information, so we can use vital records, so death certificates, birth certificates, fetal death certificates. There are certain diseases that are by law have to be reported, so if a doctor finds out that you have, or if you go in for HIV testing, that is a reportable disease. Anyone with a positive HIV test gets reported to the government. Yeah?
What is that process called specifically? Is it called mandatory
Mandatory reporting.
reporting?
Mm-hmm. Yeah.
I thought mandatory reporting was like child abuse or something.
That too. I mean, so it depends on which context you're in. So if you have mandatory reporters that are required by law to report any suspicion of child abuse or any suspicion of suicidal thoughts or homicidal thoughts, right? So certain people, teachers, therapists, once they are required by law to report if they have any suspicion of that. But so it's the same idea. You're required by law to report certain diseases if they are diagnosed. I think West Nile is a reportable disease. Syphilis. A lot of STDs are required to be reportable. I actually, in Blackboard, gave a link to the CDC's reportable disease website. So you can see a nice comprehensive list of things that have to be reported by law. Some states have additional things that have to be reported as well. But other places we can get data. Registries. So cancer registries are a wealth of data. Birth defect registries. Medical records, clinical records. These are going to become even more important as the U.S. moves towards everybody on having electronic health records. It's going to be, and theoretically, in the very near future, not only should every hospital have electronic health records, but they should all be linked so that if you go to a hospital in Timbuktu, well, technically within the United States, maybe not Timbuktu, but they will be able to access your health records from any place. So if you show up in the emergency room, they can find out that you're allergic to penicillin before they give it to you. Did you have a question? No. Okay. But so health records are an important way to gain information at this point, but they're going to only increase in importance as we go on. And then we have health surveys. So the NHIS is the National Hospital Interview Survey. If you plan on going into hospital administration, you will have learned to love that survey and know it well. The NHANES is the National Health and Nutrition Examination Survey. And It's really cool and has a bajillion types of data. If you ever have a research question, you can probably answer it with that data. And the BRFIS is the Behavioral Risk Factor Surveillance System. The government runs a whole bunch of other surveillance surveys that go on. These are all done every year on certain cycles. But so you have 20 years of data that you can look at. Questions change periodically, but there's a lot of information that can be gleaned from this type of data. All right, so that's the big spiel on surveillance. Let's talk about why surveillance is so important. To do that, we really have to talk about the difference between endemic, epidemic, and pandemic. So, epidemic is simply an increase above the expected level of disease, whereas endemic is the expected level of disease. So endemic refers to the base rate of disease in a given area. An epidemic, in layman's terms, we could call it an outbreak. They're somewhat synonymous. Some people have different connotations for the two words, but essentially an epidemic and an outbreak are the same thing. Is when you have an increase in the expected level. So anything that is an increase above and beyond what you would expect is to be the endemic rate in a certain area. And pandemic is simply a really big epidemic. So we considered H1N1 to be pandemic. It was huge all across the globe. SARS, when SARS came, do y'all remember the SARS outbreak? That was considered pandemic. HIV is considered pandemic because it was the huge influenza outbreak in, what was it, 1918? Is that the right year? Might be in the wrong year. All of that was, you guys should know that because a bunch of you did the influenza outbreak. What year was it? What? I'm sorry? I was, yeah. All right, so all of those are pandemic. A pandemic is just a really huge epidemic, right? There's no hard and fast rule as to like the threshold when it becomes a pandemic. Mm-hmm.
And pandemic has nothing to do with geography.
No, but I mean the idea is that it's across a huge geographic region. So it's not like if everyone in St. Louis got sick, that would be a huge number of people, but that wouldn't be a pandemic because it was locally focused. A pandemic is when you have a widespread distribution of everybody's above the base rate of disease. So it's just a really large epidemic. But some people, I mean, it really kind of depends on who's talking about it. Like the flu, influenza, I mean, that was a worldwide pandemic. Some things have been termed, I'm trying to think of one that's just like in the U.S., but completely eluding me at the moment. Pandemic, it's not an official, like, if you reach 100,000 people, it goes from epidemic to pandemic. It's just, you have epidemic, and then when people say, hey, this has gotten really out of hand, you start calling it a pandemic, essentially. But so there's not a hard, fast differentiation, but usually it is referring to geographic locale. Yeah, so it's largely geographically distributed. So, endemic is our base rate, epidemic is an increase above the base rate, and pandemic is we've taken that epidemic and it's spread all over the place. So, which leads us to the spread of infectious disease. So infectious disease is due to an interaction between the agent, host, and environment. This is the infectious disease triangle. An agent is any microorganism that must be present for an infection to occur. So it's any microorganism that has to be present for the infection to occur. The host is any animal in which the infection can exist. And the environment is the domain in which the agent may originate or exist. Yeah?
Please repeat.
Yes, which part? The whole thing? Host. Host is any animal in which the agent can exist.
Environment is a domain which the agent
May originate or exist, yes. Ready to repeat any of it again? Yes, no, maybe? Good. All right. So in infectious diseases, typically the agent alone is not enough to make you sick. Just being exposed to the cold virus doesn't necessarily mean that you're going to get the cold. The agent has to be housed in the right host, in the right environment. So if you have the cold virus and it's near a cow, the cow is not the right host, so the cow is not going to get infected with the cold. Right? But if it's a human, and you're in the right environment, and somebody like coughs in your face and spits on you, yeah, you're probably going to get it because you have the right agent, the right host, in the right environment. But all three of these things, that's a very simplistic view of infectious disease transmission. But in general, you have to have the right interaction between those three things in order to get sick. So infectious agents can be transmitted to humans. They can be transmitted directly through infected humans or animals, or they can be transferred indirectly through objects or vectors. So a vector are insects or animals that carry the infectious agent from person to person. So for example, a mosquito is a vector for malaria. I have malaria, I don't directly give you malaria. A mosquito bites me, gets the parasite, then bites you, it gives you the parasite, and then you get malaria. So the vector is the animal or insect that carries the virus from one person to the next. Airborne particles are just that. I sneeze, the particle droplets go through the air, you inhale them, you get a cold. If I am standing next to you and I sneeze on your face, which would be very rude and I wouldn't do, but it could happen, right? Or if your child sticks their fist in their mouth and then all of a sudden sticks it in your mouth because little kids like to do that for some reason, that's a direct transmission because like their saliva is directly on. But if I'm standing across from the room from you and I sneeze and the droplets travel, that's indirect transmission. And then vehicles are contaminated objects or elements. So, the potato salad that gave you salmonella. The doorknob that was contaminated with norovirus and you got a bad tummy ache. Those are vehicles. So, yes?
Can you repeat that again, what vehicles are?
Vehicles are contaminated objects. So things like food or doorknobs or improperly washed utensils or non-living disease distributors, I guess. All right. So infections themselves are caused by the entry and multiplication of microorganisms or parasites in humans or animals. You don't need to write that down. We all get the idea that a virus gets into your system and it multiplies and then you get sick, right? General idea. Now, many infections, you can be infected with something and not appear sick, right? So sometimes we call this subclinical infections. Infection is not synonymous with infectious disease. Because some infections never really have a clinical manifestation. So someone might have, West Nile virus is a great example. Some people get infected with West Nile virus and they never show any signs at all. Their immune system fights it off, there's no problem. Right? They didn't actually get sick. But that doesn't mean that a mosquito didn't bite them and give them the virus. So they were infected with the virus, but they didn't ever actually get sick from it. It was a subclinical thing. Infectious disease means you really got sick. So sometimes we call an infectious disease a communicable disease. Because there are also infectious disease and communicable disease are not entirely synonymous. But a communicable disease is a disease that you can get and then give to somebody else. And so these are infectious diseases or communicable diseases are diseases that are caused by the transmission of a specific pathogenic agent from one person to the next, or from one susceptible host to the next. So we can classify infectious agents according to their size, structure, and physiology. So these are the major types of infectious agents. So helminths, which are worms, fungi, protozoans, bacteria, rickettsia, viruses, and prions. And prions are the newest ones. That's what mad cow disease is. Fun stuff. Now, the characteristic of the agent determines the nature of the infection. So, like I said before, infection is not equivalent to disease. And the characteristics of the agent are important in determining how sick you're going to get. So let's walk through these. Pathogenicity refers to the agent's ability to produce disease. Now we measure pathogenicity by the ratio of the number of people that develop clinical illness to the number of people that are exposed. I will say that again. So we measure pathogenicity as the number of people who develop clinical illness, the number of people we can tell are really sick, to the number of people that were exposed to the agent. Virulence is a measure of severity of disease. So virulence can vary from very low to very high, but it's how sick you get if you get the disease. So cold, low virulence. Ebola, pretty high. Who knows what, everybody know what Ebola is? Anybody not know what Ebola is? It's a really nasty disease that causes you to kind of like bleed out through all of your orifices. It's gross.
It's like the black vomit.
Yeah, they did call it black vomit. So it's it's prevalent in Africa.
Congo?
Yes. So there's. Well, I could go all day on Ebola. It's a really fascinating disease. It's horrible. You should read The Hot Zone. Yeah. So Ebola is highly virulent. A lot of people, most people that get sick die. Where I think it's like, depending on the strain, it's like 90% of people that get it die. Infected dose is the amount of the agent required to produce the infection in susceptible individuals. So it's how much of the agent you have to get in order to actually, for it to produce the disease. So you can't just get like one little virus. You probably need to get a little bit more, like 4 or 5, I don't know, it doesn't matter. But the effective dose is how much of the agent you have to get in order to get sick. The reservoir is the agent's natural habitat, where it just kind of generally lives. Now, a reservoir could be humans, it could be animals, it could be environmental sources, but it's where the agent hangs out before it starts making people sick. And the source of the infection is the person or object from which the host acquires the agent. So the source could be me if I sneeze in your face, or the source could be the doorknob. The source is where you got sick. Right? Alright, so transmission is the second link in this chain of infection. So you have this agent, and you identified all the characteristics of the agent that make it more or less likely to cause an infection in people, clinical infection. We also have to talk about the transmission. So we talked about it briefly before, but so direct transmission means you have directly taken the agent and handed it off to somebody else. So things like touching, or kissing, or sex, or childbirth, or standing in front of you and actually like physically sneezing on someone's face. So short, distant, airborne. I don't know why I keep talking about sneezing on people's faces, but or blood contact, so bloodborne. All the things where you actually touch the thing, the body fluid or the whatever from the person to person. Indirect, we're talking vehicle-borne, vector-borne, me sneezing over here and the droplets flying across the room to you. or parenteral, which simply means that you've been injected with it. So if people are sharing dirty needles, that's parenteral indirect transmission. Remember vehicle? What's a vehicle? That was 2 slides ago, yeah.
Contaminated objects.
Yes. So if you touch the desk and the desk is all germy. Vector-borne, so if the mosquito bites you and gives you West Nile. Airborne from long distance. All right. Then we have to talk about the host. So the host is where the infection takes hold and makes you sick. Yes?
What was
Parenteral, that's through an injection. So sharing dirty needles or needles that weren't cleaned properly, but it's when it's injected, so yeah. All those people that have been getting encephalitis due to the, did you guys hear about that? The outbreaks of encephalitis from spinal, people were getting, it's supposed to be nice little spinal nerve block things to keep them from having pain, and instead they all got encephalitis. A really awful, ugly fungal encephalitis. But anyway, so the host is where the agent lives, where it can grow and multiply. Now, we, and well, every animal, have host defense mechanisms. We have ways to try to not get the infection. These can be divided into non-specific and disease-specific. So non-specific are the defense mechanisms that in general try to keep germs out, right? So you have skin so that germs don't get into the rest of you. You have tears in your eyes to try to flush out so you don't get things entering through your eyes. Saliva, gastric acids, macrophages, all of these are non-specific. They're not designed to target one specific disease or organism. They are just general things that your body has to try to keep you well. Disease-specific can be classified into natural active, artificial active, natural passive, and artificial passive. So disease-specific are your antibodies, your immune system, things that are targeted towards a specific organism. So natural active refers to immunity that results from you already having gotten infected by the agent. So back when they used to let us get chickenpox, before the chickenpox vaccine, we would get chickenpox, and then once you had gotten chickenpox, you were then immune to chickenpox again. I naturally acquired the disease, I now have a natural immunity. But it's active because I got the disease and that's how I developed the immunity. Artificial active is vaccination. So now, kids don't get the chickenpox anymore. Now they vaccinate for the chickenpox. And so they give people either a dead virus or a weakened virus, depending on what disease it is. They inject it into you, and then your body fights it off and now has an immune response to it. The same immune response you would have had when you got the chickenpox, except now you don't have to itch. Natural passive refers to short-term immunity resulting from preformed antibodies that are transferred from mother to infant. So when babies are born, they share some of their mother's antibodies. And then part of the reason that nursing is supposed to, and breastfeeding is so good for babies is that mothers are able to pass the antibodies that their body has created to their newborn. So that's natural passive. The baby isn't making the antibodies, but these are natural antibodies created by the mother that she's giving to the baby. Artificial passive refers to short-term immunity from previous, so when you take previously exposed individuals and then you take out the antibodies from them and you swirl them in a centrifuge and make them all nice and neat and then you give them to somebody else.
An example.
So there are some people that cannot have the smallpox vaccine because there's a lot of contraindications because the smallpox vaccine is dangerous. So if you have eczema, you can't have it. So if those people were exposed to smallpox, you could take someone who was immune to smallpox, you could take their blood, pull out the antibodies and then give them to the person that was exposed to smallpox, and therefore you give them short-term immunity to that disease.
And that would be implemented in the event of, say, somebody leaving the country for...
Well, no, that would only happen, I mean, smallpox is an example. Like they can, so, I'm trying to think what other diseases they use it for. There's a lot of, now that smallpox is the example that's coming to mind. But it's if you for some reason can't, or are sick with the disease and you can't fight it off yourself and you are not immune to it, but somebody else is immune to it, you can take the antibodies from that person and give them to the person that needs them, and thereby give them some immunity to that illness. But it's short term; it doesn't last forever.
Gotcha. Like in the event that they're having a surgery or something.
Yeah, probably. I don't know enough about the medical way that it works. I just know that it's a possibility. If you're really interested, I can find people that know how it works and have them talk to you. All right. So we've talked about the agent and host. Now we can talk about the environment, because the environment plays a critical role in the development of communicable diseases. So, general sanitation, temperature, air and water pollution can all influence how susceptible you are to infection. There is a reason that when you have a big natural disaster, you have all these people living in crowded conditions, that you end up with cholera outbreaks. Right? You have a whole bunch of people living closely together with poor sanitation. That environment breeds disease. Right? There's a reason that the influenza pandemic became a pandemic, because it was in the middle of a war when everybody was living in barracks and all these people were living on top of each other, and it's very easy to spread from one person to the next. Right? So you can have an environment, you can talk about the biologic characteristics of the environment, so the host characteristics, so their genetic susceptibility to particular disease. We can talk about the physical environment. We get a lot more colds in the winter than we do in the summer, right? Temperature, the weather, humidity, all of these things influence how susceptible individuals can be to disease. And then we can also talk about cultural, behavioral, and attitudes. So, for people who don't feel the need to wash their hands all the time probably get sick. I don't know if there's a culture where you don't wash your hands, but yes, there is. It's called 4-year-olds. There's a reason that children spread disease to each other, because they culturally do not like to wash their hands. They actively avoid it. And then, so you have things like factors such as like population density, poverty, all of these things that influence susceptibility to disease. All right. Now we come to the part where I'm going to tell you all why you should vaccinate your children when you have them. And it's because of this concept of herd immunity. So just as each individual has their own immune system, right? You have your own immune system that helps fight off disease. You can also view the population as its own kind of organism. And you want the population itself to be immune to a particular disease. So the immunity of the population kind of governs the susceptibility of the group. So herd immunity is the resistance of the population as a whole to the spread of an infectious agent. Basically, the concept is you don't have to immunize every single person in the population, and so long as the majority of the people in the population have been immunized to something, the likelihood of that
disease state taking hold is minimal. And this is really important because there are some people, for various reasons, who cannot be immunized. So people with egg allergies a lot of times can't have certain immunizations. People with compromised immune systems, newborn infants. There are certain groups of people who cannot be immunized for various diseases for whatever reason.
And they depend on the concept of herd immunity for their safety from disease. The breakdown in herd immunity is what you see when you hear about these outbreaks of whooping cough, pertussis in the United States. There have been several little pockets, and there are always pockets where you have these people that refuse to vaccinate their children. Because herd immunity has broken down in those areas. And it's one thing for an adult to get sick. It is quite another for a 2-month-old to get sick when you have a breakdown in herd immunity. Vaccinate your kids. Basically, public health has been a victim of its own success. We have been so successful at eradicating some of these really horrible diseases that nobody remembers how bad they were. And now we're concerned with hypothetical risks that may or may not, that probably are not in existence. And yes, vaccines do have some side effects, and there are some risks involved, but the risks are minimal compared to, I don't know, the risk of blindness and deafness from measles. So, anyway, I will get off my little soapbox. It's important because when you refuse to vaccinate your children, you are also putting the rest of the population at risk. It's not just you and your kids that are at risk, it's everybody. All right. Does everybody agree with me? Are we all going to vaccinate our children?
Yeah.
Yay! Okay. That was what I needed. We're all supposed to cheer and run screaming through the streets and carry signs. Anyway. But the point is, herd immunity is an important concept, and that actually protects the population as a whole, and it protects those individuals that cannot get immunized for whatever reason. Not to mention the fact that vaccinations don't necessarily work for everyone. So there are some people who you've been vaccinated, but for whatever reason your body didn't create enough antibodies. And so those people also depend on herd immunity for their own safety. All right. So we've talked about how infections spread. We talked about what infection is and how people get sick and all of that. But now we talk about what do we do when we notice that there's an outbreak of disease. So now we're going to talk about the fun part of outbreak investigation. So you start off with your preliminary investigation. So basically what happens, you have some little surveillance system, or you find out people are reporting a bunch of cases of suspicious illness. First thing you have to do is go out and determine that what people are reporting or what your surveillance system is showing is actually the case, so that people actually have the disease that you think that they have. So you have to gather information about the illness, so you can judge what kind of illness it is, what the agent may be. In some circumstances, you know why people are sick. Some circumstances, people are just sick and you have no idea what they have and you have to figure it out. You use this preliminary investigation to form your hypothesis. So if you have a hypothesis and you know that it's salmonella, and you have a suspicion that it's coming from this one particular restaurant, you can implement control measures right then, and then hopefully they work. Sometimes it's not that easy. You have to come up with a larger study before you can come up with a reasonable control measure. But you can start to form hypotheses in your preliminary investigation. You have to identify your cases, which involves creating a case definition, a very specific case definition. The case definition might actually change over the course of the investigation, but you want to have a case definition that helps you identify who is actually sick. You use your information from your preliminary investigation to help you develop your case definition. So then you start collecting and analyzing your data. So for people that meet your case definition, you start finding out all that you can about them, and you start analyzing the data to see if you can find connections between people that are sick. You also plot the time of onset, so you can pinpoint whether or not the infection appears to all have happened at the same time, or if it appears to be propagating from person to person to person. Then management and controlling is obviously trying to treat the cases, trying to implement control measures, and then you disseminate your findings. This is not actually a linear process. So I've written it as a list, but it's not a linear process. It's an iterative process where you go back and forth between stages wherever you need to. But in general, this is what happens when you're doing an outbreak investigation. So how is this different from what we've talked about up until this point? We don't start with a clear hypothesis. So in the analytic epi things that we've talked about up to this point, we really had a hypothesis at the start of our study. Here we don't have that. Typically we do case control studies, so we're still going to use the case control study methodology in these instances, usually. But we're not starting with a clear hypothesis. We have to have our preliminary investigation first to figure out what's going on. Unlike when we're just doing regular chronic disease analytic studies, there's an immediate need to control the situation in the population. You want to keep more people from getting sick. So if you can come up with even an idea of why people might be getting sick, it's a good idea to implement control measures at that point. And if they don't work, you figure out what works. But if they do work, then awesome, and you've controlled the situation before it got really bad. And then you have to decide what information is enough information. How many questions do you need to ask people? What do you need to ask them about? How many people do you actually need to interview before you can make a decision as to what you need to do? All right. So there's a couple of different types of epidemics. The common source epidemic is the potato salad at the picnic, where everybody ate it, they got sick, and then we're done, right? Everybody got sick at the same time from the same infectious agent, or within a very brief window of time. So this right here is called an epidemic curve. We plot out the onset of illness from everybody that meets our case definition, so when they got sick. So when you have a common source epidemic where everybody got sick at the same time, you typically see one or two, and then you have a huge peak in the number of people that get sick, and then it kind of tapers off. But you just see one kind of spike, and then that's it, when everybody got sick at the same time. And this is just reflecting the variation in the incubation period. So most diseases they'll be like an incubation period of 3 to 6 hours or 4 to 6 days or something, but there's usually a variable window of time from the time that you were infected to the time that you actually get sick. So let's say we're hypothesizing in this particular outbreak that it's due to disease X. And we know that disease X has an incubation period of 13 to 23 days. What we can do is look at the time when the first person became ill, and we can go back the minimal incubation period. So we take whatever day they first got ill, and then we're going to subtract the minimum incubation period. And then we have the last person, and we can subtract the longest incubation period. We come up with a range here, which is probably when everybody got exposed. So this works well for a common source, or sometimes you'll hear it called a point source epidemic. But what we also have are propagative or progressive epidemics. And their curves look a little bit different. So in the common source, we just had a couple of people got sick, we saw one spike, and then it came back down. Right? So everybody got sick, so once the incubation period is gone, nobody else is going to get sick. In a propagative, what ends up happening is people are passing the disease on to another. Right? So the disease is either able to be transferred from person to person, but the next person gets. So what you have the first couple of cases, and then you have a big spike in the illness, and these people start to get well, but now these people have infected a new group, and so now you start to see another spike. Right? Because these people didn't know they were sick, and so they went to work and they coughed on everybody because they were able to infect other people at the time, but they didn't know it. And so then they got sick, and now all these people, the incubation period falls, and now these people are getting sick, and so they pass it on. So diseases that are spread from person to person, this tends to happen. So when we're talking about the flu, you typically have a big, huge peak of cases, followed by the average incubation period, and then you see another spike in the curve. All right. So how do we decide how many people got sick or how bad the disease is? A lot of times we look at the attack rate. So we have the number of new cases of disease per the population at risk within a specified time period. So the number of people who got sick, the number of people that were susceptible to illness, and then times 100 because we usually want it to be a nice whole number, right? So we use the attack rate to investigate outbreaks. It's useful for describing rapidly occurring new cases of disease in well-defined populations over a limited period of time. attack rate is great for the common source epidemic. They're usually calculated with person characteristics like age, or race, ethnicity, or occupation, so we can identify high-risk groups. So we could find the attack rate within men and the attack rate within women and see if groups were differentially more or less likely to get the disease. All right, and now just a little bit of things of infection control in healthcare settings. So, healthcare-associated infections, so people that go into the hospital and then develop a nosocomial infection from being in the hospital, cost the healthcare industry a tremendous amount of money. Therefore, there is a huge incentive to try to prevent hospital-acquired infection, right? We have, so, yes, this, I should probably update it. I think that we probably have newer data actually but I mean, 1,737,125 healthcare-associated infections in the hospital in the United States in 2002 alone. That's a lot of people that got sick at the place where they were supposed to be getting well, right? So, this is the reason that pretty much every hospital has its own infection control unit. And what those people do, they usually staff epidemiologists and they have infection control doctors, and those people are responsible for identifying outbreaks of nosocomial infections within the hospital environment and then shutting it down, figuring out why people got sick. So like Medicare right now won't reimburse hospitals for hospital-acquired infections. So those people cost a lot of money. They're really sick. But if it's a hospital-acquired infection, Medicare won't reimburse the hospital for it. Because basically they're saying it's the hospital's fault they got sick. So a lot of healthcare dollars are lost and fought over due to this. But the point of these infectious control programs that pretty much all hospitals have is to keep the patients, the staff, and their visitors from getting sick while they're at the hospital. Now the important thing though is these programs have to be cost effective. So it doesn't make sense to spend $5 billion trying to prevent people from getting something that's going to cost the hospital $1 billion, right? Maybe not. So there's some cost effectiveness analysis. But we do this in the hospital. It's just kind of a mini microcosm of the type of infectious disease outbreak investigation that we were talking about earlier. You're just doing it in the hospital. You're looking at, there's routine surveillance for certain diseases throughout the hospital, the ones that are most likely to be hospital-acquired infections. There's measures that are put into place to help try to prevent it, and then try to control outbreaks when they happen. All right. So that is all we have.